Good afternoon. My name's Tony Kelleher. I'm Director of the Kirby Institute, and I want to thank you for joining us for our latest instalment in the Kirby Institute seminar series, which today will be called Understanding COVID-19, New Therapeutics and Clinical Challenges, which will be presented by Associate Professor Gail Matthews and Dr. Marianne Martinello. I'd like to begin by acknowledging the traditional custodians of the lands on which we are all gathered on today and pay my respects to their elders, past, present and emerging. And I extend that respect to Aboriginal and Torres Strait Islanders peoples who might be joining us today. Some housekeeping to start off with. The format of the seminar will start off with a combined presentation from both speakers, followed by a Q&A at the end. When you join the webinar, your camera and microphone are automatically disabled. You can interact by typing your questions throughout the talk. To ask a question, if you're on a mobile device, click on the icon with a speech bubble and question mark in the top right-hand corner to open the Q&A chat screen. If you're viewing from a desktop, the Q&A chat panel will open automatically on the right. When you click on Ask a Question, please remember to write your name. This will reference your question and make answering easier. You can upvote any question you would like to be answered, and you can change the order of the questions by clicking on the tab on the top right of the Q&A chat, which says most recent, and changing that to most liked. So as I said, today's topic is Understanding COVID-19, New Therapeutics and Clinical Challenges. And this will be presented by Associate Professor Gail Matthews, who is a clinical academic and associate professor at the Kirby Institute. She is a UNSW Scientia Fellow and Head of Infectious Diseases at St. Vincent's Hospital, where she has been closely involved in managing the hospital's response to COVID-19. And she will be followed by Dr. Marianne Martinello, who is also a clinical academic here at the Kirby and an infectious diseases physician at Blacktown Hospital. At the Kirby, she is a Senior Research Fellow and NHMRC Early Career Fellow in the Viral Hepatitis and Clinical Research Program at the Kirby, and an infectious diseases physician at Blacktown, Mount Druitt Hospital, and at St. Vincent's Correctional Health in Sydney. She is involved in both research and clinical care of people with COVID-19. Gail, over to you.
Thank you, Tony, and welcome to all of you who are out there. These are mine and Marianne's disclosures. The way the session is going to work today is that I'm going to start by covering off COVID-19 and its somewhat atypical clinical presentations. Marianne will then talk about therapeutics for COVID-19 and some of the latest data, and then I'll finish with a short session on some of the implications potentially for practice. Now, it's really been an astonishing amount of evidence that has been collected over a very short period of time since COVID-19, or the novel SARS-CoV-2 virus first was reported. And just over 3.5 months ago, in fact, this report in JAMA of over 72,000 cases from the Chinese CDC, 44,000 of them confirmed as SARS-CoV-2 positive or COVID-19, describing for the first time the natural history of this new disease, and noting that over 81% of these patients have a mild to moderate disease presentation, but 14% have a more severe presentation with a pneumonic process, and 5% of people become critically ill. The case fatality rate in this series was recorded as 2.3%. Now, since that time, globally, almost 7 million COVID-19 infections have been reported, and we're very well aware of the common presenting features, which are those that you might expect from a respiratory virus, which is what COVID-19 is. So fever, cough, fatigue, shortness of breath, and anorexia. A number of other symptoms also reported of varying degrees, which you might again expect with a viral infection. Of note, though, nasal congestion, the typical common cold or stuffiness, only reported actually in a very small proportion of patients. Now, those small number of patients that become severely unwell are a key to understanding the pathophysiology of COVID-19 is to understand why these individuals do become unwell. They present with an illness typically manifest as an acute respiratory distress syndrome, or ARDS, characterized by severe lack of oxygen and lung edema. Now, what drives mortality in this group? Understanding that can help us understand what is behind the biology of COVID-19. Only a few weeks ago, a group reported in The Lancet from New York, one of the epicenters of COVID-19, a prospective cohort study in 2 hospitals. They reported on over 1,000 hospitalized COVID-19 positive patients, of whom approximately 22% they defined as critically ill, requiring a high-flow nasal oxygen or invasive ventilation. The presenting features of this group were similar to what we might expect: shortness of breath, fever, cough, myalgia, and a significant proportion presenting with diarrhea. The median age was 62 and about 2/3 were men. As we now know, a large proportion of these patients, over 82%, had at least one comorbidity. Almost 80% of them required invasive ventilation, and over 1/3 died of their infection. These authors then tried to look at what was predictive of in-hospital mortality to understand why some patients died and whether there are any clues to the pathophysiology. Now, some of those factors in multivariate analysis we know to be associated with more severe disease, so age and chronic comorbidities of cardiac disease and lung disease. But I really just want to draw your attention to these biomarkers, which in this series were clearly associated with an increased risk of death. And these point to some of the processes that underlie severe COVID-19. So a raised interleukin-6, a pro-inflammatory cytokine, and a raised D-dimer. Now, coagulopathy in COVID-19 is increasingly recognised as one of the key underlying processes that causes severe disease in these patients. An elevated D-dimer, and a D-dimer is a protein fragment that's broken down in the body in the situation of clots. So when a clot breaks down, it releases D-dimer, and this could be measured. And an elevated D-dimer is one of the key laboratory findings of COVID-19 disease. It's been recognised as being associated with severe disease, ICU requirement, and lack of survival in a number of studies, many of them originating from China. Now, patients who are very severely unwell with, for example, sepsis can certainly get elevated D-dimers as part of a condition called DIC, or disseminated intravascular coagulation. However, the D-dimer associated with COVID-19 seems to be representing quite a new, distinct coagulopathy. It's not typically associated with the low platelet count or the prolonged clotting times that the DIC that we see in people who are severely unwell with sepsis present. It's quite a different presentation of a coagulopathy. And it's often associated with what's been recognised to be a cytokine storm. And what this implies is that the virus is somehow triggering, either directly or indirectly, high concentrations of pro-inflammatory cytokines in the blood. So these include TNF-alpha, interleukin-1, interleukin-6, and these all drive endogenous anticoagulant pathways leading to a microvascular thrombosis. Coagulopathy in COVID-19, as I said, is increasingly recognised as a significant problem in the severe end of the spectrum. And thrombotic events are very common despite standard prophylaxis. In a Dutch study of 184 intensive care patients across 3 hospitals published in mid-April, 31% of patients, almost 1/3, despite having prophylaxis, had a composite outcome of a thrombotic event, a major thrombotic event. Most of them had acute pulmonary embolisms or clots, but they also had venous thrombosis, ischemic stroke, myocardial infarction, and systemic arterial clots. Now, this group also subsequently published again a couple of weeks later, reporting that that original rate of 31% had actually risen to 46% of their individuals having a major thrombotic event in intensive care. This isn't isolated in that study. It's been reported now increasingly from many other studies. A multi-centre prospective study from 4 French intensive cares over a period of a month published in early May. All of their patients, again, were receiving prophylactic or therapeutic anticoagulation, as might be expected in patients who are in intensive care. They still recorded 64 new thrombotic events in 150 patients. A large number of those, again, were pulmonary embolism. I think this CT scan here is nice. It was published in that paper because it shows the very typical lungs of a patient with COVID-19 severe pneumonia with significant consolidation in both lung fields, but pointing there, the blue arrow to a large pulmonary embolus, suggesting that this was contributing to the respiratory failure potentially seen in these patients. This group also looked at the issue of whether this coagulopathy was typical of that seen in other patients with ARDS. So they measured a number of parameters, including D-dimer, fibrinogen, some other clotting parameters, and they compared them in their COVID-19 ARDS patients to a group of non-COVID-19 ARDS patients, a historical control group. And they found that the parameters were significantly different in the COVID-related ARDS as opposed to the non-COVID-related ARDS, suggesting that this, again, is a new form of hypercoagulable state seen specifically, potentially, in the COVID-19 disease. And it raises the question, I think, whether the hypercoagulable state of COVID-19 is in fact responsible for many of its manifestations. So as we turn to look at neurological manifestations of COVID-19, and this is an area which is again getting increasing attention in terms of atypical presentations. Now, headache and dizziness are common symptoms occurring in around 10 to 20% of individuals with COVID-19, and that may not be too unexpected in somebody with a viral infection. However, more atypical presentations are now being reported. On the 28th of April, the New England Journal reported in its case reports section reports of large vessel stroke occurring in young patients, so that's under the age of 50 years. This was a centre in New York reporting that 5 patients under the age of 50 presented with ischemic stroke over a 2-week period in their emergency department, and noting that their usual rate would be less than 1 per month. 2 of these patients had no co-risk factors. One was a 33-year-old female, one was a 37-year-old male, and the others had mild diabetes and some hypertension. All were SARS-CoV-2 positive, and the group here suggesting that this may be a particular new atypical presentation of COVID-19. In fact, if we go back and we look at the preprint, an article from Wuhan in April, early April, reporting on 221 hospitalized COVID patients in China, and 5.7% of them suffering an acute ischemic stroke as a presentation, and the fibrin and D-dimer levels, again, approximately 12-fold higher than usual, suggesting a significant coagulopathy present in these patients. Now, that group subsequently published their data formally in JAMA Neurology at the end of April. 214 hospitalized patients in 3 hospitals in Wuhan, describing the range of neurological manifestations in this population. Now, just over a third, in fact, of patients had evidence of some kind of neurological involvement, and in fact, that rose to almost half of those who were identified as having severe disease. They divided the neurological manifestations into central, peripheral and musculoskeletal manifestations, noting, as from before, 5.7% had an acute cerebrovascular event, mainly a large vessel stroke. There was a significant amount of impaired consciousness, and this was in the absence of sedation for ventilation, etc., suggesting that encephalopathy may be a real feature of a COVID-19 infection. And again, a significant proportion of them had skeletal muscle disturbance. And the authors noted that in some of these cases, in fact, the neurological presentation was the only presenting complaint without respiratory manifestation. And interestingly, around the same time, the first reports of an encephalitis related to SARS-CoV-2, with a report of a patient presenting in Japan with encephalitis, and in this patient, SARS-CoV-2 virus was found in the CSF, but interestingly not in nasal swabs. A further group presented a review of neurological manifestations and put up this image, which I think nicely summarizes the different manifestations or ways in which the virus of COVID-19 may affect the neurological presentation. So in the top left there, a suggestion that there may be direct neuronal invasion through the olfactory bulb and causing cell death in the brain itself. Alternatively, in panel B, the virus may travel in the blood from the lungs and enter through the ACE2 expression into cells through the blood-brain barrier and causing, again, brain edema and neuronal cell death. The third postulated mechanism is through autoantibody formation. And we know that coronaviruses can cause autoantibody-mediated encephalitis and other neurological syndromes such as Guillain-Barré. And the fourth mechanism these authors postulated was that the stress, the severe environmental stress of COVID-19 could cause activation of the hypothalamic pituitary axis stress release, and that this may in some way result in a number of psychiatric syndromes related to COVID-19. Now, I think the mechanism behind this are poorly understood, but there certainly is a whole range of data coming out on the potential neuropsychiatric manifestations of COVID-19, and there's much more for us to discover in that area. I do just want to go back and focus on this, though, which is the invasion of SARS-CoV-2 virus through the olfactory bulb, because it leads us to one of the very atypical presentations of COVID-19, which is the loss of smell and the loss of taste. Now, loss of smell in the general population is described in around 3 to 20% of individuals, but early case reports over the last couple of months and in social media have begun to describe the loss of taste and smell specifically associated with COVID-19 infection. And then this nice paper by Spector and colleagues in the 11th of May, published in Nature Medicine, and this was a large study, predominantly UK, but also with some US participation. Over 1 month, almost, well, over 2.5 million participants in this study, so a huge study, recorded symptoms on a smartphone app called COVID Symptomatic Checker. Now, 18,000 of those individuals were subsequently tested for COVID-19, and just over 7,000 of them were found to be COVID-19 positive. So the authors were able to do an analysis looking at symptom reporting related to positivity. Now, they found the loss of smell or taste to be reported in 65% of COVID positive individuals versus 22% of COVID negative individuals, with an odds ratio of just under 7. And in that graph there on the right, you can see the strength of the odds ratio association of loss and smell for a diagnosis of COVID-19 as compared to some of those other, maybe more common symptoms. The authors also put together a symptom combined model, which they combined age, gender, cough, anorexia and fatigue with specifically with loss of smell, and found that they were able to predict COVID-19 in around 70 to 80% of their individuals. And they postulated that on the basis of that, it was likely that almost 20% of individuals in this study had been infected. And the same authors have subsequently argued that a loss of smell in COVID-19 could be considered a common enough and specific enough symptom to suggest that people who have no access to testing could self-isolate. So loss of smell and taste is now recognised as an early and sometimes often symptom of COVID-19. It's been adopted by the CDC and I think also now subsequently by WHO as a COVID symptom. The range at which it occurs is quite variable, because clearly there's been, as it's become more reported in media, people have been more aware of the symptoms, so there's been some bias there. But it's estimated to occur in around 1/3 to 2/3 of individuals who are infected. The sensitivity is less, it's in the range of 40 to 60% for COVID-19, but it has a high specificity in today's current climate of around 90%. Now, an interesting paper by some French infectious disease centres in the Lancet Infectious Diseases looked at a combination of symptoms of loss of taste, loss of smell, and an absence of ENT symptoms, so no nasal obstruction. Remembering I said at the start that very few patients actually with COVID-19 have the stuffy, congested nose, but they found that with the combination of these, that the specificity was as high as 95% for the diagnosis of COVID-19. Is it biologically plausible? Well, certainly it probably is. There's a high concentration of the ACE2 protein and expression in nasal epithelial mucosa, and this is the protein that the virus needs to enter. So it can travel up and enter through the olfactory bulb, destroying as it does so the olfactory neurons, contributing to the loss of smell, and therefore potentially entering directly into neuronal tissue. We know other coronaviruses are neurotropic, and in fact intranasal inoculation of the SARS-1 virus in mice was shown to be directly neuroinvasive through the olfactory bulb, causing widespread neuronal death in mice. And I think it raises the question of whether some of the respiratory failure seen in the COVID-19 patients is potentially related to a SARS-CoV-2 neural involvement, killing off cells potentially in the medulla oblongata. I want to just finally finish in terms of looking at atypical presentations of COVID-19 by talking about Kawasaki-like disease. So Kawasaki disease was first reported in Japan in the late 60s, around 50 cases at that time. And it's known to represent an acute, usually self-limiting medium vessel vasculitis, often affecting the coronary vessels. Now, it's a disease usually of young children. Nobody actually really understands the pathophysiology completely, but it probably represents an abnormal immune response to unidentified pathogens. It's likely to have a underlying genetic predisposition and typically affecting those of Asian inheritance. It's uncommon, with the incidence approximately 9 to 10 per 100,000, and can be epidemic. Kawasaki syndrome is characterized, the classic syndrome is characterized by persistent fever, rash, bilateral conjunctivitis, lymph node swelling, usually on one side, involvement of the palms and soles and mucosal lesions. But there are many incomplete forms that exist of Kawasaki syndrome, partly reflecting the uncertainty in the underlying pathophysiology. And there's also a form of the disease called Kawasaki disease shock syndrome, which includes a low blood pressure or hypertension, and often requires inotropic support in intensive care settings. The cardiac involvement usually is in the form of coronary aneurysms and resulting in poor cardiac function. Now, back in mid-May, so this is only a month ago, Verdoni and colleagues in the Lancet reported from Bergamo, the epicenter of the Italian COVID-19 epidemic. And they reported on a retrospective review of Kawasaki-like cases presenting in their area between a 1 month period from March to April 2020. The usual incidence in the 5 years in the area that they were reporting from in the 5 years preceding this period was an average of 0.3 cases per month, with an average age of 3 years. In the 1 month period that they described, 10 cases were seen with an average age which is older. It was around 7 years, and representing a 30-fold increase in incidence of this syndrome in their area. 5 of these presentations had typical Kawasaki disease with fever, conjunctivitis and rash, and 5 had a more severe presentation, often with atypical features, including encephalitis and diarrhea as a presenting feature. And some significant lab disturbances were observed, including again a coagulopathy with a raised D-dimer level and evidence of cytokine storm. So shock and inotrope support for blood pressure were common, requiring immunoglobulin and steroid support with aspirin. Now, interestingly, not all of these children were PCR positive. In fact, very few were, only 2 out of 10, but most were serologically positive, implying that this was a late manifestation of COVID-19 infection. Now, This is not just been reported from Italy. 8 cases in South London at around the same time were reported of a hyperinflammatory shock-like illness in children with COVID-19 over just a 10-day period. Again, the age was somewhat older than you might expect with Kawasaki disease. The majority were Afro-Caribbean. Fever, rash, conjunctivitis, swollen limbs, all features of Kawasaki disease were common, but a lot of these children presented with significant abdominal pain and proceeded to develop shock. Most had no respiratory symptoms and all initially were PCR negative for the virus. Elevated coagulation markers and evidence of cardiac involvement was common, with aneurysm formation and high troponin levels. Now, almost all of these children had a COVID epidemiological risk for COVID, and subsequently all became antibody positive. Now, this original 8 cases was subsequently expanded to include 37 affected children. I just read this morning it's now been expanded to 57 children across England. And leading to the British Paediatric Society naming this syndrome a new syndrome, Paediatric Inflammatory Multisystem Syndrome, temporarily associated with the SARS-CoV-2 virus, or PIMTS. And at the same time in the United States, this time with a different name, Multisystem Inflammatory Syndrome in Children, or MISC-C, a similar syndrome though presenting with very features akin to the other UK and Italian cases, and this time recognised in over 100 cases in New York City with 3 deaths, and leading to a CDC health advisory alert for this syndrome in mid-May. So it's clear that whether you call it Kawasaki disease or PIMS-TS or MISC-C, what we see here is a post-infectious inflammatory syndrome, probably mediated by immunity and with similar features to the severe features of COVID-19 in adults. It clearly has an evolving name, there's an evolving definition of the disease, an evolving association that we understand with COVID-19, and it requires, I think, an evolving approach to therapy. And with that, I'm going to hand over to Marianne, who's now going to talk about some of the therapeutic options.
Thanks, Gail. So let's move from clinical challenges to therapeutic ones. So in the next 20 minutes or so, we'll discuss what's happening in the clinical trial space for COVID-19. And to begin with, I want to manage all of your expectations. This talk is not going to tell you how to treat anyone with COVID-19. It's going to provide an overview of some of the proposed antiviral and immune-based therapeutic interventions. And right off the bat, I'm going to let you all know that there is no agent that has been specifically shown to reduce hospitalisation or mortality for people with COVID-19. So if that's what you're expecting, you can turn off. And then we'll follow with some brief comments about one of the success stories of the last few months, and that's large national and international clinical trial collaborations. So to begin, as you're all aware, there has been a vast amount of research proposed for COVID-19, and certainly just looking in the clinical trial space, there's more than 1,900 interventional studies of treatment or prevention for COVID-19 on the WHO International Clinical Trials Registry, and similarly on the NIH Clinical Trials Registry, they've got more than 1,300 studies. Very few of these are federally funded. Even smaller number are industry funded. By far and away, the vast majority are investigator initiated. And they're across a whole raft of possible proposed investigational agents, from repurposed antivirals to immunomodulatory drugs to unproven cell therapies to vitamin C, vitamin D, honey. If you look, it's there. But today we'll focus on a few of those agents that have been studied in a little more detail. So in particular, those that have been compared to a control or usual care. And we'll focus on some of the antiviral agents. And then of the immune-based therapies, we'll focus on convalescent plasma or passive immunotherapy. Again, just to ground everyone so that you know what we're talking about, this is SARS-CoV-2 virus and its replication cycle. So we have the virus entering the cell here. In terms of different targets for therapy or prevention, obviously we have a vaccine from a preventive point of view, but when we're talking about passive immunotherapy or the role of convalescent plasma. We're really talking about neutralizing antibodies directed largely against the spike protein on the surface of the SARS-CoV-2 virus. Following this, there are various agents that have been proposed that may have some effectiveness, including repurposed HIV protease inhibitors and RNA-dependent RNA polymerase inhibitors, which people may be more familiar in hearing about in the realm of hepatitis C, a drug like sofosbuvir. And lastly, after we've had antiviral targets, we have those drugs that may be effective against the inflammatory reaction prompted by SARS-CoV-2 infection, which may be broad in the case of interferon or corticosteroids, or be more narrow in their effectiveness, like the IL-6 receptor antagonist, like tocilizumab. So just before we go any further, there are a few things that I want you to keep at the back of your mind while we're talking about the clinical trials in this over the next 15 minutes or so, but also when you come to read any other study about SARS-CoV-2 or therapy for COVID-19. First of all, look at the study design. Is there a control group? Are they true controls? And what is usual care? So remember, we're talking about comparing an investigational agent with a control for a virus or a disease that didn't exist 6 months ago. And certainly usual care for an acute respiratory virus in a pandemic situation, in an overwhelmed healthcare setting, is very different from what we would normally do. Is the study comparing a single agent or combination therapy? Obviously, if you've got combination therapy, it's more difficult to tease out any specific effect of any one part of that. And what's the primary endpoint? You'll see that as we go through that most of these are time to clinical improvement, time to symptom resolution, time to PCR negativity, time to radiological improvement. They're not necessarily hard endpoints that we would like mortality or hospitalisation. But the time to clinical improvement has been accepted for other studies of acute respiratory viruses, particularly influenza. And lots of that is pragmatic, because for a study to be powered to assess mortality, you would need thousands of patients. Next, think about the natural history of COVID-19. This is something that we've knowledge that is evolving and has evolved over the last few months. And so you need to remember that when these clinical trial protocols were being written, the knowledge of COVID-19 was in its infancy. And so some of the study endpoints for these clinical trials were changed as the trials were ongoing, as we knew more about it. We also now know that perhaps the timing of interventions in the disease process may be important, with certain things being more appropriate early on in the disease, i.e. potentially antivirals or convalescent plasma, as opposed to other things that may be more useful later in the disease course, like immunomodulatory therapy. And lastly, just a brief note on mortality. So obviously what we would all like to do is prevent death from COVID-19 if we could. But it's highly likely that if we find any agent, particularly in this early phase investigation, any impact it's going to have is going to be modest. It might be in the order of 5 to 10%, which means that the number needed to treat could be 10, 20, 30 people. And so most people who receive that intervention may not actually derive benefit. And that might be something that clinicians and the public find a little difficult to understand. But let's go on and discuss some of the specific therapeutics. And obviously we have to start with chloroquine and hydroxychloroquine because they've had the most media attention and they certainly have the most clinical trial designs related to them. So these are antimalarial agents. They also have some immunomodulatory properties. So hydroxychloroquine is used for SLE and rheumatoid arthritis. They have some notable toxicities, which I'm sure you've heard about in the mainstream media, including retinal toxicity and cardiac toxicity, in particular QTc prolongation and propensity for arrhythmia. They have been shown to have in vitro activity against a variety of viruses, SARS-1, MERS, chikungunya virus, Nipah, Zika, Hep C, but have not been shown to be clinically effective for any of those things and certainly not in use for any of them. In February of this year, it was also shown to have in vitro activity against SARS-CoV-2, and that's then led to a number of clinical studies. It's also led to every expert out there providing their opinion on whether or not hydroxychloroquine should be used for treatment of COVID-19. But what do we actually know? First of all, what don't we know? There's been some, I'm sure most of you are aware of the controversy in the media and in the medical literature about this observational study that was published in The Lancet. It's since been revoked, given that the authors were unable to verify the source of the data. But essentially, in its original publication, it suggested that the receipt of hydroxychloroquine or chloroquine was associated with greater mortality amongst people with COVID-19. And that obviously provided considerable concern for ethics boards around the world. And so they recommended that for clinical trials that were currently ongoing and in which hydroxychloroquine was an arm, that those trials were halted and data was reviewed. And one of the studies that did halt enrolment and which provided an interim review of their data was the recovery trial. So this is a very large adaptive clinical trial platform in the UK. More than 11,000 people have been randomised to this so far, and people are randomised to standard of care or one of 5 arms. One of the arms was hydroxychloroquine, and in an interim analysis, the investigators found there was no difference in 28-day mortality between people who received hydroxychloroquine as compared with usual care. They also said that there was no evidence of a beneficial effect on hospital duration or other outcomes. So obviously we'll await the formal publication of this data and appropriate peer review, but hopefully this might make the research community pivot to other therapeutics which may show more promise. So it doesn't look as if hydroxychloroquine is going to be the answer, despite what Donald Trump might say. Next, lopinavir/ritonavir, which many of you will be familiar with from work in HIV. Darunavir, another HIV protease inhibitor, has shown to have in vitro efficacy against SARS-CoV-2, though not lopinavir per se. There was some data from SARS-1, which is why it was picked up again to assess in this setting. This is the only clinical trial that's been published to date, which compares lopinavir/ritonavir with usual care. Almost 200 adults in China. As you can see, there was no difference in time to clinical improvement or 28-day mortality in those who received lopinavir/ritonavir or usual care. Now, a couple of points to note. This study was markedly underpowered because of control of the outbreak in Wuhan much earlier than expected. Recruitment was halted in March before they'd achieved their appropriate sample size. So the results in that regard are inconclusive, although if there was to be any benefit, you would think it would be very marginal. The other thing to note is that there were a large number of participants ceased treatment for adverse events in the lopinavir/ritonavir arm, largely gastrointestinal, consistent with the side effect profile that we're already aware of. So while lopinavir/ritonavir is still being evaluated in multiple trials around the world, it may not be the agent to hang your hat on. Thirdly, remdesivir. This is where we might start to see some promise. So this is an investigational agent with Gilead. It was originally discovered on drug screening for RNA viruses. It's got very broad activity. There was some initial in vitro work done with hepatitis C. It then had a bit of a clinical revival and was evaluated as a treatment for Ebola, with publication in 2016, found not to be effective here. And it's now being re-evaluated again for SARS-CoV-2. It does have in vitro activity. It needs to be given intravenously because of its high first pass metabolism. So that has some impact on its potential clinical utility. But this is one drug where we might start to see some modest benefit. So the first RCT that was published was this one out of Wuhan by Wang and colleagues. Adults with severe COVID-19 were randomised 2-to-1 to receive either 10 days of remdesivir or placebo plus usual care. Again, this is where I want to point out what is usual care, because in this study, usual care was allowed to include such things as corticosteroids and lopinavir-ritonavir, which in themselves are investigational agents. And about a third of people received steroids, which are now not recommended by the WHO and others. The primary outcome for this study was time to clinical improvement at 28 days. You can see that there was no difference in time to clinical improvement or mortality in either the remdesivir group or the control arm. But again, as with the study of looking at Kaletra, this study was terminated early because of control of the outbreak. And so these results were inconclusive. This study is the one that's perhaps sparked the most appropriate attention, the ACT-1 trial sponsored by the NIH, and is what led to the FDA listing remdesivir for emergency use access. So in this large adaptive clinical trial, patients were randomised 1-to-1 to receive remdesivir for 10 days or placebo. The study is currently ongoing, largely in North America, but with sites in Mexico, Europe, the UK, and in Asia. You'll notice that this definition or the enrolment of participants here is slightly broader in that they included people who had both moderate and severe COVID-19. Their primary outcome was time to recovery at 28 days, which were either discharged alive or hospitalised for infection control purposes. In those people who received remdesivir, time to recovery was 11 days, as compared with those who received the control, which was 15 days, and this difference of 4 days was statistically significant. So it appeared that those people who received remdesivir got better more quickly. Now, in looking at mortality at 14 days, so not 28 days, because this was an interim analysis, remember, there was no statistically significant difference, but we do need to wait for all the participants to complete follow-up and for the final data set to be published before we can make any final call on any mortality difference in this group. Although it looked favourable for remdesivir, but again, a very small absolute difference, but that's not unsurprising for an acute respiratory virus. If you are going to use remdesivir, it might be that there are certain patient groups that derive the most benefit. And here you can see that it did appear that those people who did better with remdesivir or got better more quickly were those who had less severe disease. So these were patients requiring oxygen, but not those who required non-invasive ventilation like BiPAP or mechanical ventilation or ECMO. So it might be that you need to choose which patient group is most likely to derive benefit, i.e. earlier in the disease process. And lastly, we have this study, which was so far only been released as a press release by Gilead. This is the SIMPLE study, which randomised people into 3 arms, 1-to-1-to-1, adults and children with moderate COVID-19. So as compared with the other studies where most of them had severe disease with stats of less than 94%, these people all had to have oxygen saturations of greater than 94%. These people were randomised to 10 days of remdesivir, 5 days of remdesivir or usual care. And the primary outcome here was clinical state at day 11. And as you would be expected for people who have more moderate disease, most people improved by day 11, with 70% improving in those who received 5 days, 65% improving in those who received 10 days, and 61% improving in those who received usual care. And the difference between those who received 5 days of remdesivir and usual care was statistically significant. As you can see, very few people died, but again, that's as you would expect in a group with moderate disease. Lastly, let's look at convalescent plasma and what role that could play. So convalescent plasma, on the thought of using it for infectious diseases, has been around for a very long time. There's some articles related to 1918 influenza pandemic. There's also meta-analyses suggesting benefit for SARS-1 and for H1N1 influenza. But what about in SARS-CoV-2? This is the first randomised clinical trial published last week. There were some initial case reports out of China that suggested benefit prior to this. So in this study, again, performed in Wuhan, patients with severe or life-threatening COVID were randomised to convalescent plasma and usual care or usual care. Primary outcome again, clinical improvement at day 28. As you can see, again, there was no statistically significant difference in either clinical improvement or mortality, although the trend was towards convalescent plasma being beneficial. And for the third time in studies performed in Wuhan, unfortunately, this study was inconclusive, given that the study was terminated early, given lack of participants to recruit. So unfortunately, they only recruited 50%. If you look a little bit deeper though in this paper, on one of their pre-specified secondary analyses, it did look as if participants who had severe disease, so not those with life-threatening disease, but with severe disease, appeared to derive the most benefit. So perhaps in future evaluation of convalescent plasma, this may be the patient group that you would go for, and that makes biological sense. And lastly, just to finish, I think it's worth pointing out that probably one of the greatest success, while we don't have an answer for how to treat COVID-19, there have been some amazing collaborations between academic and government partners in setting up very large adaptive clinical trial platforms. The UK is one example. So the UK government and NHS said, if you want to treat someone with COVID-19, you have to enrol in one of these 3 studies. Principal, which is in the community, Recovery, which is for hospitalised patients, and REMAP-CAP for people in ICU. Similarly, the WHO has launched Solidarity in multiple countries around the world, and Discovery, which I guess is a daughter, is named a daughter trial of Solidarity, but which is sponsored by INSERM, similarly is a large adaptive platform across Europe. And while we might not think that the US can offer as much, they've also remarkably put together a therapeutic interventions and vaccines partnership called ACTIVE with a number of NIH and industry partners to look at all stages of clinical and therapeutic development for COVID-19.
Thanks, Marianne. So I just wanted to finish really with a few slides regarding what we've talked about. And I think what you can tell from what I've talked about and Marianne has talked about is that some of what's been discovered, if you like, over the last or understood over the last few months raises more questions than it answers. So I really just wanted to talk about some implications for practice and maybe just some reflections around how this has affected us at the local level, just to finish with. So I think the first thing to say is that when we see patients presenting in a novel clinical way, we have to develop novel pathways and novel models of care to cope with that. So at the hospital level, right at the start of the COVID-19 epidemic here in Australia, we assumed, I think, that everybody would be coming into hospital presenting pretty much like influenza with severe respiratory infection. And so the pathways were established to to cater to that. Clearly, as we've become more aware that people may present with neurological involvement or gastrointestinal involvement or cardiac involvement, I haven't talked much about cardiac, but it's raised questions, which means we have to change and adapt the way we do things, because now we have to think, well, who do we test for COVID-19? It's obviously not just the respiratory patient that comes into hospital, and that's led to some of the guidelines around who gets tested for hospital changing over the last few weeks. And as a need to adapt to that, the hospitals have had to change how they deal with that, because it clearly means once you start testing that we have to change how we manage patients, and this means putting patients in isolation, and it's really been quite a stretch on the way pathways have been thought about in the hospital, that now we have to consider every patient who may come into hospital with a fever and an atypical presentation as having COVID-19. We have to think who gets involved in those pathways. So these atypical presentations has really led us very much to reconsidering how we approach patients potentially coming to our services with COVID-19. The second thing I wanted to say about implications of practice, and Marianne's touched on it in her talk on therapies, is that clearly different therapies are going to be very different, are going to be very important at different time points. So if you want to deal with the virus, then you really have to use therapies in the first 8 to 10 days, because that's when the virus is present. And after that, the virus is gone, and the host immune response, which I talked about, being responsible for many of the severe manifestations, is kicking in much later in the time course of illness, when people start to become unwell and become hospitalized. So maybe what is needed at this stage of the disease process, the cytokine storm stage, the immunomodulation, the anticoagulation, I talked about the thrombotic events, that's very different from what may be needed if you're going to try and attack at the virus, the viremic phase. And this is where your antiviral and or your antibody combination, whether it's convalescent plasma, whether it's a monoclonal antibody, this is when you might expect it to have most effect. However, given, as we know from the natural history, that almost 80% of people in the viremic phase are not going to progress through to severe manifestations of disease, I think it's going to be a real challenge to understand how these combinations, even if they're proven to be useful, how they're going to be used and how they're going to be paid for as well. And what we really urgently need, I think, is a biomarker for disease progression to identify which of those 80% of patients or the patients who become viremic with COVID-19 are going to not progress, and which are the smaller number that are going to progress. Clearly, at the end of the day, what we ultimately need is a vaccine. I think whilst we're understanding all the things that we don't know about COVID-19, we really need to just keep doing what we do well. I do want to, I guess, give a call out here to the non-therapeutic actions which have prevented cases. So this is the effectiveness of public health interventions, which we know have in Australia been so effective in preventing new cases of COVID-19. Now, this is data from the St Vincent's and associated testing clinics, including Bondi, which has been collected over the past 9 weeks, demonstrating the number of tests performed per week. And you can see increased testing after the opening up of pop-up clinics and after the broadening of testing criteria, but at the same time physical distancing introduced, and the marked reduction there in all respiratory pathogens. So SARS in the yellow, but rhinovirus, the commonest, in the red bar there, and you can see the effectiveness of these public health interventions and what they've done in reducing respiratory virus transmission. The other thing that we've done really well, or that can be done really well when you have the capability, is if you have enough ventilators and you have the ability to give excellent respiratory support, then you can keep your case fatality rate low. So this is some work by Bezard in our group. It's been submitted looking at the case fatality risk in Australia, and demonstrating that aside from the very elderly, where we do know there is an increased case fatality, that the the case fatality rate in the younger groups, the under 70s, actually is very low. It is stabilised to around 1.5%. And I think that's because we've had the capacity to be able to give the best possible care we can to patients, the patients who do become so severely unwell. And I guess this is my final slide, and what I wanted to talk about here is how early we are on the journey to understanding post-COVID recovery and what that might mean for patients. And so there is clearly many things we still do not understand about the clinical manifestations of COVID long term, including whether it leads to any degree of post-viral fatigue, whether there is any long-term neuropsychological impairment related to the neurological manifestations that I discussed earlier, whether there is the potential to have long-term cardiac abnormalities and lung function impairment, whether there is any possibility of getting a re-challenge type syndrome similar to dengue, whereby patients get exposed again, whether their immune systems go into overdrive, leading to further cytokine storm. And certainly what we don't understand yet, but what we're starting to see, is some of the issues for patients around significant stress, stigma and discrimination as a result of their COVID infection. And so I just wanted to say that we are trying, there are a number of studies, research studies across both Kirby and St Vincent's Hospital, really trying to understand some of these maybe longer term clinical features of COVID-19 that we still don't yet fully understand. Thank you.
Thanks, Gail and Marianne, for absolutely fantastic presentations there that have summarised a huge amount of information very succinctly. There have been some questions as we've gone through, and I'd encourage you to put questions up in the chat window. Gail, if I could ask about the pathophysiology, it seems to be very much based on vascular, of the severe disease seems to be based on vascular disturbance. Do you think there's any link with the interaction with the ACE receptor, since that is, very important for regulation of vasculature?
Yes, look, I think they're very well maybe. I mean, the whole interaction, I think, is very complicated with ACE2 and the coagulation disturbances that we see. I mean, we haven't had time to present all the data on all the different modalities, but certainly there is a big trial of looking at ACE blockers, and I think that will maybe give us some of the answers as to whether that helps with also managing some of those thrombotic or coagulation presentations.
And to Marianne or to you, Gail, on the same sort of theme, there were questions about whether people were looking at the use of anti-clotting drugs for therapy. So you said that people were on routine prophylaxis, but are there other things being looked at?
Yeah.
Yeah, look, I mean, I think people are looking at various other forms of anticoagulation, and I think, as Marianne said, I mean, the problem is when you design these studies, you're always playing catch up. So the studies that were designed, 3 months ago or even 6 months ago, I don't think recognised maybe that the coagulopathy would be such a main feature of COVID-19. So I'm sure that we're starting to see more studies of different modalities of anticoagulation. Certainly, I know there's a study of nebulized heparin, which is being done at St Vincent's in Melbourne, and that's an interesting idea because it's looking at nebulized heparin to attack the microthrombi that may be in the pulmonary vasculature that may be responsible for the very stiff lungs of COVID-19 lungs. So I know that, and I think there are probably some other studies of anticoagulation therapeutics.
Yeah, I think more broadly, as Gail has said, I think now that we understand, not that we fully understand, but now that we understand the natural history of COVID-19 slightly better, I think there will need to be more nuanced clinical trials that focus therapeutics to specific areas, as opposed to the broad brush approach that we've had up to this point.
There was also a question, given the rarity of the Kawasaki-like disease in kids, were there any hints about a genetic predisposition at this early point?
So I think that's difficult. I mean, clearly in most of the studies that I have seen, there is a predominance of Afro-Caribbean and Black children who've been affected, but that's also true of the COVID-19 epidemic in those settings anyway. So I think I don't know the answer to that. I think it's something that we really need to understand, and I think that's why it's so important that there's all this collaborative work being done, not just in terms of therapeutics, but also in terms of biobanking and getting together large cohorts of patients who've had COVID-19 with samples and with data, so that these really important questions around genetics, and again, what drives the genetics? Is there a genetic epitotype that drives progression to severe disease, for example? I know that's a question that some of the researchers here at the Garvan are very interested in answering it in conjunction with, international collaborations, and studies like ADAPT and COSIN are collecting samples to be able to contribute to that. So I think it really is a very collaborative effort to try and understand some of these questions.
Marianne, I was going to ask you about convalescent plasma and who might be the ideal donor, given that there is this worry from what Gail presented, that there are potential immune factors that mediate severe disease. What sort of screening and that sort of thing should there be for convalescent donors?
Yeah, I mean, yes, so there is always the theoretical possibility that receipt of plasma from a convalescent donor could result in a re-challenge type or the kind of augmentation of an inflammatory phenomena, as has been seen with dengue. But I think from the study that has been published out of Wuhan, that was in JAMA, I think a well-characterised donation with IgG that show with neutralisation, that has neutralisation antibodies, I think it looked like it was safe. There certainly wasn't a safety signal in the most recent publication. So I think if you've got well-characterised plasma donation, you know that you've got neutralising antibodies to SARS-CoV-2, I think it's reasonable to take forward in a clinical trial setting. Okay, and there was one final question about whether the loss of the sense of smell, Gail, that you described, is that permanent or does that recover, and over what time period?
Well, again, I mean, if you think about it, it's only been a few months, so I don't think we know the answer to that long time. I understand from the data that it's mainly coming out of the UK, where they've had a lot of cases, and they're describing this, that most of the cases do resolve within a few weeks, but there are some cases that are still ongoing, given, as I say, it's only been 3 or 4 months anyway. So not all of the cases that have been described have fully resolved at this stage. So I don't think we know whether any of those will then become long-term cases of anosmia. And again, this is why we need to, everybody needs to follow these patients and understand, trying to characterise exactly what does happen in the disease course.
Okay, thanks very much. Thank you to our two extraordinary speakers for doing such up-to-date and accurate presentations. And thank you all for joining us. Thanks very much.
Thank you.
Thanks.